Thank you so much for the invitation from the organizers. I've been given the task today to talk about cutting-edge trials in structural heart disease at the Texas Heart Institute. This is a very exciting time to be a structuralist, but I'd like to first of all acknowledge every single one in my team, in our team that does this. And in the pictures there is Dr. Simpson, Dr. Conero, Dr. Coselli, and Dr. Leal, but more importantly, the people that make what I call the sauce, which are the MPs, the patient navigators, the business coordinators, the research team. So it essentially really takes a village to do this kind of trial, and you're going to see the tasks and the challenges that we have. So the surgeons know very well how to treat mitral and tricuspid valve disease. So you see here in this slide that the surgeons can use mitral valve repair, mitral valve replacement, tricuspid valve repair, tricuspid valve replacement. So us as interventionalists have started with mitral valve repair, as I'm going to show you, but I'm going to show you one of the trials that we're using now, that we're using a new percutaneous valve. So this is the Intrepid valve. It's a valve that's made of nitinol, which is a self-expanding metal, and you have an outer brim that essentially the valve is in the middle, and you have a brim that serves as a centering measurement for the valve, and the actual valve is in the middle working. So this valve, we started using this in 2019, and you see here to your right that there is a big sheath, a big tube inside the left ventricle through a cut down, through a transapical access done by the surgeon, and we deploy the valve. So the original trial was of a transapical, and then we randomized to surgical mitral valves, and now we are actually having a single arm, but for patients that are not candidates to transcatheter edge-to-edge repair. So now this has evolved tremendously, and we now have a system that is a transeptal system, meaning we don't have to cut, the surgeon doesn't have to cut, Dr. Coselli or Dr. Leal don't have to cut and open the left chest to get to the apex of the heart. So there's a 35 French transfemoral axis, and you see here to your left that it looks like an instrument where we can control the valve, and we go from the right atrium to the left atrium, put a balloon, and then through that hole in the transeptal, we deploy the valve inside the mitral valve. We have two sizes, 42 and 48, which creates problems because sometimes the valves are much bigger, so a 54 one is being developed. The problem with those valves in the mitral position is that whenever we put a valve inside the old valve, especially the anterior leaflet, is not taken away. So the anterior leaflet gets displaced and goes in front of the left ventricular outflow tract and creates what we call a neo-LVOT, and potentially can have LVOT obstruction. So this series of patients that I'm going to present a little bit of the results of it, the first 30 transeptal patients in the country, 3 of them had issues with LVOT obstruction that were dynamic, and one of them had to have the valve explanted, despite the fact that there is a fantastic amount of work behind it, especially with CT sizing those neo-LVOTs. But needless to say that despite all those issues, and despite the issues of patient selection and neo-LVOT, you see here that in the top part of the graph you have a 26% mortality with transapical at 1 year, and a 0 mortality with transeptal. Of course, those patient populations are different. This is different trials, but just to keep in perspective that very likely the transeptal is going to be a game changer. So how about mitral valve repair? We have been using the edge-to-edge repair with the MitraClip since 2015, and it works really well. It positions the clips very well, but it does have its challenges. So we actually now started working with the PASCAL system, which is a system that has main advantages. It's much more reliable, the positioning. It actually it's more flexible, and there are different characteristics that make the navigation a lot better and a lot easier. So we do have 2 trials. One is the CLASP 2D and 2F, which does the PASCAL device to the mitral valve, and CLASP 2 TEER, which is the one that addresses the tricuspid valve. So again, the PASCAL delivery system is a 22 French guide sheath. the catheter maneuver in 3D independent planes, and you see here that the handles are a lot easier, a lot more intuitive to manage. Independent catheters allow predictable implant positioning. This is a study that was published in JACC. You see here to your left the MitraClip. So the problem with the MitraClip is that you get a great result while it's attached, and whenever you release it, up to 30% of the patients, the mitral regurgitation gets worse inside the cath lab, and you need to put a second. So it's not that predictable in a third of the patients. In the PASCAL, you see here that only 5% of the patients have a difference in MR after you release the device. So this potentially can be a trial that will move further the field of transcatheter edge-to-edge repair. You see here, this is led here by Dr. Conero at the Texas Heart Institute Baylor College of Medicine. We're now using this mainly for patients with functional MR, as the degenerative MR arm has been completed. So again, this is a randomized trial. It's randomized against MitraClip. It's going to be very interesting to see the results, and I'm very excited about this trial. In terms of tricuspid valve repair, the surgeons have been doing this for years, and they know that this is a very difficult patient population. In fact, if you look at the surgical literature, the mortality rate of a tricuspid valve repair, isolated tricuspid valve repair, can be up to 8, 13, sometimes 18%, depending on the patient. Tricuspid valve repair is mainly done for patients that have mitral valve surgery. So we're dealing now percutaneously with a population that doesn't have a lot of options, because those patients many times get to us so advanced in the disease that the surgeon, rightfully so, says the mortality is too high to address them. So this is a patient that came to us. You see here in a transthoracic echo, and the top part is your right ventricle and this tricuspid valve, and you see here quite a bit amount of tricuspid regurgitation. This is what they call severe torrential tricuspid regurgitation, and you see to your right that the mortality of those patients with severe TR is up to 36% in a year, which is worse than many, many cancers. So this is a population that, despite the fact that they don't have a lot of symptoms sometimes, the mortality is really, really high. So the Class 2 TR trial is a prospective multicenter randomized trial that will actually randomize this against medical therapy. So the clip and the PASCAL will be randomized against diuretics mainly, which is the only therapy that we have for TR. And this is going to give us a new window for the natural history of untreated tricuspid regurgitation. So the issue with tricuspid regurgitation, and the main challenge that we have, is imaging. You see here that you have transesophageal imaging that sometimes is very difficult, but what's happening now is that because of the new development of those technologies, the imagers have stepped up to the plate. Dr. Conero in our institution, and we actually know now a lot more about the tricuspid valve's anatomy. In fact, there are different types of, sometimes the tricuspid valve is not tricuspid, it has more than 5 leaflets. And what we do is we approximate between the septal leaflet and the posterior leaflet, or the septal leaflet and the anterior leaflet. So this is an example. Here again, we use the PASCAL device, where you have those 3 independent handles. And in this case here, so see here in our patient that had quite a bit of TR from the beginning in the left side, we actually approximated the leaflets between the septal leaflet and the posterior leaflet. There's still quite a bit of tricuspid regurgitation afterwards. It's actually mild to moderate. In fact, which is very interesting in those patients, is that once you reduce them from severe to moderate, or from torrential to moderate, or in this case, severe to torrential to mild to moderate, they do extremely well. This gentleman is 1 year out. He's been he's back exercising. Granted, he's not doing CrossFit, but he's walking and having a great quality of life. So this has led to a increased awareness of what is tricuspid regurgitation. And in this study by Prihadi here, you can see that there are things that predict if the tricuspid regurgitation is going to get worse. In the middle there, You see here one of the main ones is also the size of the annulus. We know now that if you evolve rapidly from mild to moderate to a severe tricuspid regurgitation, it can be really bad and have a really bad outcome and high mortality. We want to be treating patients that are stage 3. Patients that have severe tricuspid regurgitation, mild RV dysfunction, and that are quote-unquote stable. Unfortunately, what we're doing now is most of the times we're treating patients stage 4, stage 5, which mainly sometimes get them out of the trials. So it's also a matter of us going out to the community and doing things like the global forum that we're doing today to spread the word that we now have a treatment for tricuspid regurgitation. So in conclusion, the percutaneous treatment of mitral regurgitation is a reality with transcatheter edge-to-edge repair. New devices are being developed for a mitral valve replacement. The current trials will likely result in very different treatment paradigms that we have had for the treatment of secondary and primary TEER. And this is not the forgotten valve anymore. This is the valve that will likely occupy a lot of our cath labs, a lot of our times, and will do a lot of good for a lot of our patients here at the Texas Heart Institute and Baylor College of Medicine. Thank you very much.